The Journey of Frail Elderly Patients Through Hospitals and Skilled Nursing Facilities by Ben Temkin and Catherine Kramer. This is Ted. Ted is 78, an artist and a retired New York City theater director. He's also my partner. At the beginning of this term, he was living at home in the Adirondacks at his art farm, with medical support from aides coming in several times a day. He's medically frail with several comorbidities. In early September, he got bit by a deer tick, which infected him with Lyme disease. It took a month for that to be diagnosed, during which time he got very ill. The roundabout. Soon Ted was cycling between home, the emergency room, and the hospital, becoming sicker, and he nearly died. He was discharged twice by Elizabethtown Community Hospital, part of the UVM system, only to be back in less than 24 hours. Shortly after the second discharge, he broke his ankle by falling in the bathroom at home. I decided to model this situation as a MOCS project. On the third time into the ER, Ted was able to exit the roundabout and enter what's called subacute care. Subacute care usually takes place in a skilled nursing facility, also known as a nursing home. Medicare pays for 100 days of subacute, after which the patient enters long-term care, which may be paid for by Medicaid. In New York State, approximately 20,000 residents of skilled nursing facilities have died of COVID. In New York State, since the beginning of the pandemic, the ratio of nursing staff to nursing home residents has dropped by 12%. An incoming New York State law will require 3.5 hours of nursing care per resident day, HPRD. Nursing homeowners are suing to keep it from taking effect. Nursing home staff are not evenly distributed in nursing facilities. Ted started in subacute rehab in North Creek, in the lower left of this slide. That was in mid-October, and he was transferred a few days ago to Ticonderoga, also in the lower left, which is slightly better staffed.
Because this is a fairly nuanced system, we had several ideas for how to model it. Our first one was to use a compartmental approach. This was because we were looking at the movement of a population of patients between several discrete states. We hope to use this model to understand the effect of transfer weights on patients between each state and to test whether the patients are heavily affected by how often they can return home from subacute care. The model consists of 6 states: home, the emergency room, the hospital, displaced, subacute care, and long-term care. Most of the states are fairly self-explanatory, but displaced refers to those patients who have been evicted from their hospital rooms due to a lack of available beds and are moving to another state shortly. Below are the set of equations that govern transfers from each state. I won't go over them here for the sake of time, but feel free to pause and look over them. There were quite a few concessions that we had to make when designing the model, many more than we really felt comfortable with. To go over some big ones, administrative decisions are absent from the model, so gatekeepers who actually decide who is allowed to be admitted where have no say. There's no COVID or any really exterior forces applied to the patients. We assume a well-mixed population within each state without differentiating between possible institutions or ownerships. And while we do base our transfer rates on real-world data, that data is only for the state of New York and therefore does not represent the country as a whole. The main test we chose to run on this model was to vary the recovery rate from subacute care using time spent at home as a measurement for overall health. While our results do show patients spending more time at home, the higher the recovery rate, we don't see as large of an increase as we'd hope to see with a 100% recovery rate. While our results do support our hypothesis, we realized there were several problems with this model. Along with some of the difficulties listed here, one of the largest problems was that transferring between states was based on expected values rather than individual patient conditions. This compounded with our difficulties with timescaling and our fixed population, leading to many of our patients getting stuck in long-term care far too quickly. For our second model, we chose an agent-based approach, which would allow us to employ more robust transfer rules with a focus on the condition of individual patients. We also wanted to expand the functionality of the model, adding many of the aspects that were absent from the previous model. Namely, among these are incorporating administrative agents that admit patients to different states. One thing we learned from our previous model was that staying healthy seemed to be more important than recovering and returning home. So what we wanted to see with this model was how impactful the gatekeepers who distribute the care are on the system. The states in the model are mostly the same, though we no longer need the in-between state for patients who have been dispatched from the hospital, as we can handle that directly. Additionally, we've reincorporated death into this model because we're tracking individual conditions, which allows us to prevent our population from sliding all into one state that they can't escape from. However, many of these states have additional functionality that we weren't able to work in the previous model, such as bed limits, the number of time steps that an individual is allowed to stay, the number of free beds available, and another variable is miscellaneous patients. These are patients who take up beds but are not part of our elderly population, but nevertheless take up space that they could have. Time is much more straightforward in this model, with each time step being equivalent to 1 day. For our test runs, we used a 5-year time frame, and every patient makes their move in the same order. Ideally, this would be randomized in future runs. Patients' age is tracked, and so naturally they do age as the run progresses. States are again well mixed, but now patients transfer between states based on their time in the current state and their overall health condition. Moving on to our agents, in this model we have two. The first are the individual patients who move between the states depending on their current state and condition, and the gatekeepers who decide whether or not patients are allowed to move to the state that they want to, depending on a cost function that we defined. These cost functions are based on behaviors such as trying to give each patient the best care possible or maximize profit from each patient. Patients have a condition which denotes their overall health, a state which denotes the current state they're in, a status which keeps track of whether or not they are deteriorating rapidly, stable, or recovering, time spent in the current state, which is a simple track of how many days they've spent in their current state, average number of hours cares needed. This is largely for cost function for the gatekeepers, and the chance that an accident will happen causing their health to deteriorate. While there are far fewer than our compartmental model, we still do have some notable simplifications. Overall health condition is what we keep track of. This doesn't take into account mental health separately. It doesn't account for specific injuries that may take longer to heal or heal differently, such as broken bones. Our transfer rules between each state, while much more robust, are still relatively general, and in reality would depend heavily on the doctors and patients involved. And once again, we're not taking into account external diseases or COVID. We had plans to, but we decided to cut it for this model, largely due to complexity, and we wanted to focus on effectively the best case scenario. This mostly means that while recovering, our patients are much safer than they might be in reality. Going back to our hypothesis, we designed 4 relatively simple gatekeeper profiles designed to mimic potential behaviors that these administrators could exhibit while determining who gets admitted for care. Additionally, since we're now tracking it directly, we can use the overall condition of the population as our metric this time. Our fair gatekeeper allocates bed space to those who are in most need of it. Fast tries to move as many people through the system to maximize profits. Naive will always admit anybody if they have space, but won't kick them out until they're fully healed. And malicious will almost never let anybody in, refusing care. And as you can see from the figure on the right here, the attitude of the gatekeeper has a drastic effect on the overall health of the population. Another detail of note is how all of the gatekeepers, except for the fair one, cause the overall condition of the population to downtrend, although some much more harshly than others. This lends itself to the idea that this sort of administrative duty isn't trivial, and any negligence on the part of these gatekeepers can have severe consequences for the patients. With our agent-based model, we were able to incorporate many more of the nuances of our system, as well as track more meaningful and pointed metrics. And unsurprisingly, gatekeepers do have an immense influence on patient health, and any mistakes made while performing these duties due to negligence or bias could have drastic consequences. In the future, we'd like to expand our agent-based model. This would include curating patient profiles to match real-world patients, to add additional gatekeeper functions, mimicking other patterns of behavior, incorporating COVID and other external health risks to our states, and to incorporate more geographical variables, such as facility specifications or staffing concerns.